This week on the BackTable podcast.
My takeaway is not so much everybody should be on a GLP-1, right? The takeaway is that, wow, we have a drug now that can not only help people with their cardiovascular risk, and I think there's sleep apnea benefits. One study, I think that they're looking at it for addiction, right? It's doing a lot of good for a lot of people. I think the good that it might do for cancer is not necessarily a primary cancer prevention so much as it's getting people generally healthier, reducing inflammation in their body, which then in turn is maybe reducing their risk of colorectal cancer. And so I think it's more of like, I don't know that this is necessarily ready for prime time, so to speak, of let's roll out GLP-1s as a cancer prevention tactic for everybody, so much as these medicines are extremely valuable and helpful to control obesity, which has multiple health benefits, which includes reducing cancer risk.
Hi, everybody. My name is Jun Gong. I'm a medical oncologist at Cedars-Sinai Medical Center, and it's my absolute pleasure to have Dr. Shruti Patel on this latest episode of BackTable Tumor Board. She is a GI medical oncologist and a clinical assistant professor at Stanford. So we're happy to have her here on the podcast. Dr. Patel, welcome.
Thank you so much for having me. I'm excited to chat.
Awesome. We're all excited. There was a lot of breakthrough studies recently in colorectal cancer. And I thought we'd take some time to highlight some of the key studies from GI ASCO, as well as some other studies that are potentially practice-changing in the colorectal cancer landscape. Starting with GI ASCO, metastatic breakthroughs, I would like to touch base on the BREAKWATER Cohort 3 study, which was recently presented as a plenary session. Dr. Patel, would you be able to give us an overview of the study design for this study?
Yeah, absolutely. So it was a randomized phase 3, open label trial. Basically, they looked at patients with BRAF V600E mutated metastatic colorectal cancer, randomized them 1-to-1 encorafenib, cetuximab plus FOLFIRI, and compared to FOLFIRI plus bevacizumab. And the idea behind this trial really was seeing, the first BREAKWATER, which was published last year, was looking at FOLFOX plus encorafenib, cetuximab, and obviously was a positive trial. But the reality of, we know in practice, is that not everybody uses FOLFOX first line. And so this was kind of a cohort of that original big BREAKWATER trial that looked at, compared these two and looked at overall survival and all of those things.
Excellent. And what do you think were the key findings from this presentation?
Yeah, so what they found was overall response rate was better with the triplet, called triplet, but it's actually 4 drugs, 64.4% compared to 39.2%. The overall survival is actually immature, but it showed a trend to OS benefit in the FOLFIRI plus encorafenib cetuximab arm versus the control arm. And so that's probably the big overall takeaways in terms of efficacy.
And it looks like the safety profile was pretty consistent with what we expect with our experience with EC and FOLFIRI as well. And it's great to see that this is really reassuring us of the activity given the prior FOLFOX EC results, which did have an overall survival benefit, as you've alluded to. So now with this new breakthrough reassuring us that both FOLFOX and FOLFIRI plus encorafenib and cetuximab are appropriate, essentially first-line standard of this molecular subset, how do you choose in the clinic between those that get FOLFOX versus FOLFIRI backbone with EC in this subset?
Yeah, so the way I think about it is I would argue that FOLFOX plus encorafenib cetuximab is still the better established first-line default. BREAKWATER with modified FOLFOX has already matured, OS benefit almost doubled and so that's kind of what I would lean towards. I think it was a 7-month to 15-month around kind of difference in terms of overall survival. Now, that being said, obviously this data is compelling and there is a group of patients who are not eligible for oxaliplatin, right? Whether it's they have previous neuropathy, they're in jobs that require them not to have neuropathy. And so that's one part of it. In my practice, I probably would use FOLFIRI and encorafenib cetuximab in a patient population like that. But then the other part of the reality is different doctors globally use different first-line regimens, right? And I think historically, United States is more FOLFOX first, and then Europe's more FOLFIRI first. And so I think people who tend to grab FOLFIRI in the first line for their non-BRAF mutated patients, right, are probably really happy to see this data because it's more in line with their practice of how they treat first-line patients.
Now, that's a great breakdown into the nuances of some patients that may be better for FOLFOX versus those that may be better for FOLFIRI. If one was to use FOLFIRI, encorafenib, and cetuximab in the standard clinical practice, what do you think about the bolus dosing of the 5-FU and the Areno dosing? Do you use that dosing in real-world practice, or is it a little bit different?
Yeah, I would say I'd say the dose that they used in this, I think it was 180 milligrams per meter squared for the irinotecan, which I would say is pretty standard. I use it standardly, and of course, dose reduce if depending on symptoms. But I love the question about the 5-FU bolus, because I will say that I think real world practice then diverges from these clinical trials that are, have got to use the bolus, which they do in this clinical trial. I do not use the bolus I would say not just regularly. I haven't used the bolus ever in clinical practice. And I think that there's real world analysis to support that. You're saving your patient's toxicity, not compromising efficacy. And so, that's the regimen they studied, but that's not how I personally delivered. And I think that's a reasonable kind of way to approach it.
No, we do the same thing here at Cedars as well. We don't give the bolus 5-FU. Sometimes we actually even start at a lower dose of the Areno to 150 milligrams per meter squared.
Yeah.
I think we follow the clinical trial protocol on trial, but it's great to see that we are really implementing some of our real world practices as well into this treatment as well. And a little bit of a related but tangential question. There was an FDA label change that recommended DPD testing on all patients getting fluoropyrimidine, bolus or no bolus, or even with capecitabine as well. How are you implementing that in your practice? Because it'll be relevant for these newer regimens as well.
Yeah. So I got to tell you, how we're implementing this is I've actually had like a sit down with my nurse navigator, and I'm like, any patient that comes to me as a GI oncologist, except HCC, right? If you see liver cell, you're fine. But any patient needs DPYD testing. And obviously we've gone through the counseling and all of that, and she's amazing and excellent and is able to have those conversations, because I think the biggest limitation to getting DPYD testing, it's not that doctors don't want to get it, but usually by the time we see them, it's been a certain period of time. By the time we get turnaround from the testing, we're like, we want to start the patient. So then you have to have this risk-benefit discussion. But if the test is done early, that's kind of I think the best way to mitigate all these even discussions about, do we just talk about the risks and get started sooner? Oh, if they're obstructing, we really have to get started, and what are the risks and benefits? But to your point, I think the FDA updated its label. The NCCN also is saying you got to do this. There was at ASCO GI this year, one of my colleagues from Stanford, Thomas Holden, actually gave the talk on DPYD deficiency. And so we at Stanford have been talking about it nonstop because of that. And I think, and some of these ctDNA companies and these NGS companies are also starting to test DPYD with, when you send off liquid biopsy. And so I do think everybody is moving towards that. I do think there is a lot of hesitancy in uptake. And I would say understandably, I think it's a workflow thing that hasn't really been established. I do think we need to start thinking about it as like a biomarker. We cannot, we should not proceed unless there is severe clinical urgency, which I don't think we're quite there yet just as a field. But I like that there are concrete steps that are being taken by the FDA, by NCCN, to really kind of show us like, hey, this is what you should be doing, and here's kind of like the evidence, No,
that's great. So it's great to hear the availability of liquid platforms, tissue NGS platforms, commercial platforms that are readily available. And it's reassuring to hear that Stanford is really leading the pack in advocating for widespread testing. With that note, I think there's one last question I want to ask about the BREAKWATER study. There's been some discussion about saving the encorafenib cetuximab combination for second line, for example, and favoring, for example, a triplet in the first line. What are your thoughts on this in preferring combination up front or sequencing the targeted therapy combination to after?
Yeah, I gotta say, I think that's a little bit, for me, hard to defend in like a clinical scenario. And that's in part because what BREAKWATER did, right, was prove that putting our targeted agents up front is valuable. Now, the part about sequencing, if you don't think they can tolerate all of them right up front, there was an arm of the original BREAKWATER that compared to encorafenib cetuximab alone. Honestly, that arm I felt was a very provocative arm because sometimes you're like, oh, my patient's like too sick, right, to get all of the drugs. I don't know that I want to give them chemo necessarily. I would almost want to switch those where I would feel more comfortable giving encorafenib cetuximab up front, possibly saving the chemo for later. Now, I'm already anticipating the argument that, maybe they're going to be sicker later and maybe you would want to save the targeted for later. But I don't know, just look with the data that was published last year, I find saving the targeted therapy, especially in this population that we know gets sick and it has a highly aggressive cancer, I would say that is tough for me.
Yeah, I think that's a very valid point. And I think the field is moving in different tumor types to really give your best punch first as well. And we've seen how the resistance mechanisms work and they evolve with this. And we see that significant drop off in efficacy even when you move on to second line. So I think that's the right decision to try to get the best punch up front. Well,
Yeah.
that was great. So moving on to another metastatic CRC presentation that happened at GI ASCO. This was the COMET study. And Dr. Patel, did you want to take us over the design for this study?
Absolutely. So this was a prospective randomized phase 3 study as well, open label. It was in first-line mismatch repair deficient, MSI high, metastatic colorectal cancer, and originally was 1:1:1 FOLFOX Bev versus Atezo versus FOLFOX Bev and Atezo. And then the FOLFOX and Bev arm was then closed after Keynote 177 was published. And then after actually Checkmate 8HW published, accrual was actually suspended to the results of Checkmate 8HW. And so that's kind of the general gist of the study.
And what was the key findings?
Yeah, so the key findings were very interesting, and I feel like you got to really listen up because it's to tell the listeners. The median PFS was 24.5 months versus 5.3 months in the Atezo alone arm. So I'm going to say it again, 24.5 months for the chemo plus Atezo plus Bev versus the arm that was Atezo alone, which was 5.3 months. And the overall response rate for the intervention arm, so again, chemo plus Atezo Bev, was 86.1, and the ORR for the Atezo alone arm was 46%.
So you said you emphasize those efficacy results multiple times. Put that in the context of what we know from the other immunotherapy trials. What is the takeaway for you from this study?
Yeah, so the takeaway was, first of all, I think all of us feel like the Atezo arm underperformed what we would expect, right? So for context, Keynote 177, median PFS of 16.5 months for Pembro alone. So like our single agent immunotherapy that we all are used to using, 16.5 months. It's about a 10-month difference, a little more than a 10-month difference, which is shocking, right? And then our Checkmate 8HW, which led to the kind of suspension of this trial, had about a 24-month PFS. And so the reason why I was emphasizing all of that, of course, is because, when you see, I think this is just general for clinical trials, is when you see a clinical trial and you're like, oh, positive trial, this is great. I'm going to, use this the next day. It's obviously so important for us to also look at the control arm, contextualize it in relation to what we know about other trials that have been randomized phase 3. And of course, we're not supposed to cross-trial comparison, but the reality is we have an understanding of disease biology. We have an understanding of what immunotherapy does in these mismatch repair deficient patients. And so I just think it's important to really take a look at that. Does that make sense?
Yeah, no, that was great context. And so is there any situation where you can imagine using a chemo backbone with immunotherapy in your MSI high patients?
Yeah. So so I think the big takeaway from COMMIT, it's really hard to imagine. I'll admit that. it is a very niche situation, I think, that you're using the chemo plus the immunotherapy, just because the dual immunotherapy, if you're really looking for efficacy, exists, right? But the one thing I do think that the chemo showed us is that, if you have a patient has bulky liver disease, you are threatened, or any sort of threatened organ function, obstructive symptoms, the reality is that we know immunotherapy takes some time to work, right? And so considering this at the beginning, right, and then maybe dropping off with the chemotherapy as you've gotten some control of your tumor, if that's what's needed in the person in front of you, is probably a situation that I would genuinely think about it. But in general, I think that it's probably not going to be used very often across the board.
Got it. And you highlighted the efficacy of the doublet. Is the doublet your preferred choice? Is there any situations where you use monotherapy as well in the MSI-high population?
Yeah, absolutely. So I do use monotherapy in a select group of patients. I would say that my preferred is absolutely the doublet. If I think the patient could tolerate it, which most patients that come in, I would say that they can. But of course, there's the rare patient that's very old or frail, and not just old, but old and frail, right? Because we know age is not the only thing that we need to look at. Or if we're worried about immune-related side effects, there are definitely some patients with some mild autoimmune conditions that we still do consider immunotherapy in if they are in this kind of situation. But maybe we're going to hold back on the CTLA-4 inhibition with kind of the good results with pembro alone. And so that's probably the situation I would think about it in.
Well said. And I think another takeaway that's often underappreciated was, did COMET, should they be praised for appropriately closing an accrual after new, practice-changing results happened? That's often hard to do that, to close an entire study. Do you think they did the right thing?
I think it's incredible. I think everyone should do that. I think no one does that. Not no one does that. But, I think that is absolutely should be praised in the same way that I think we should publish a lot of negative trials, and we should learn from all the, not mistakes, but failures, right? And there's a lot to be learned. And so I think that they did a great job in that. And I think it should be praised. And I think more trials should do that, is my take.
Absolutely. Absolutely. We share the same stance on that. So moving on, that was 2 great GI ASCO presentations. The next study was actually a presentation at the main ASCO previously, but wanted to discuss it because potential practice-changing implications, at least in the MSS space. We've been talking about MSI-high recently. So I wanted to highlight the Stellar 303, which was just published. Dr. Patel, could you take us through what this study design was?
Yeah, so it's a global randomized phase 3, so all similar to the last few trials we just talked about. MSS, metastatic, colorectal cancer, refractory, so now this is different, right, than the last few trials we talked about. Refractory or intolerant to 5-FU, irinotecan, oxaliplatin, with or without a VEGF monoclonal antibody, so BEV usually, or an anti-EGFR antibody, and a BRAF inhibitor. So really, you've gone through it all, or you've been intolerant to it all. And what they did was they randomized to, I still struggle saying the name, I'll admit it. I call it Zanza, but zanzalintinib and atezolizumab versus regorafenib, which is something obviously we all know that we use in the refractory setting in metastatic colorectal cancer. And so what they found, I'm just going to jump to that, is median OS was 10.9 months compared to 9.4 months when you compared kind of this TKI, which is what the Zanza is, plus immunotherapy, the atezo, compared to regorafenib. So 10.9 versus 9.4. And then the interim OS, and I think this is important, we'll probably talk about it in a second, is the interim OS in the non-liver metastasis population. Median was 15.9 months versus 12.7 months. So I think that's important, and I'm sure we'll talk about it in a second.
Yeah. No, thank you for highlighting those key outcomes. And this was heralded as the first positive, really phase 3 MSS trial with an IO-based regimen, basically. So what do you think? How do you see this regimen fitting into your treatment paradigm for refractory mCRC?
So I gotta say, I I love this study. I'm like a huge believer in immunotherapy and MSS. I will say that. So like I worked on a paper with two of my colleagues, Dr. Evan Beater, who is a chief resident at Stanford, and Dr. Christopher Chen, who is my colleague at Stanford. And we actually looked at an aggregate analysis of multiple immunotherapy trials in metastatic colorectal cancer. And in our, search, we found that patients without liver metastasis consistently demonstrated higher response rates, improved survival outcomes compared to those who had liver involvement. And so we're a pretty big, I'm like, I would say me and Chris and are pretty big believers in this immunotherapy story in metastatic colorectal cancer, MSS. And so when we found that Stellar was coming out, we were very, very excited about it when the press release came out. And essentially, I think this fits in very well, right? I think, and I'm probably going to reach for it earlier than I am reaching for, obviously we're still waiting for more data, but Lonsurf, Bev, Rego, all of those, only because, especially in my patients without liver metastasis, sorry, to clarify. Mm-hmm. I do think the liver mets do matter. And I think that is, of course, the approval will be in all patients, but I do think in patients with liver mets, I think that's a longer discussion about what we really think the benefit will be. But I think that there is, a trial like this is really valuable because when you look at all these failed trials we've had in the past, right, with immunotherapy in this space, and you look at the subgroup analysis, and you look at the non-liver met groups. Sorry, now I'm turning myself around. When you look at the subgroups of patients without liver mets, and you look at the response rates, they are comparable, if not better, than some of these TKIs that we have standalone. And so I'm obviously very happy for our patients that this trial was positive, but this isn't just like this one drug is my take on this. It's a class effect. I think immunotherapy can work in patients who do not have liver metastases. And the way I think about it is if I had a loved one, right, knock on wood, but if I had a loved one who was in that situation, what would I want them to have right now and did not have liver mets? Like, that's what I would want to give them.
No, that's an excellent take. And I echo what you said about patients have been wanting this for a long time. They always ask about immunotherapy in our clinic almost every day. And aside from clinical trials in an MSS population, I think this is a really needed breakthrough to have in this subset here. With that being said, do you feel that you would still use it in a liver met population, but maybe not as early as you would in a non-liver met population with this combination, once assuming approval?
Yeah, I think I would, again, because I do think that there's like something about immunotherapy and durability of response. And, we look at all the immunotherapy trials across every tumor type, and not every single one, but in most of them, you're seeing some sort of tail, right? You're seeing at 5 years, there's some tail. And so I think that there is value if you are going to get a responder, and this trial is showing that there is a benefit in this population. I probably would use it. I do have some thoughts about do you think it would be helpful to treat the liver mets before you put them on? And I think there's so much more data. It'd be so interesting to know in the non-responders, was the growth only in the liver? Could you do liver-directed therapy in addition? We have so many liver-directed therapy options. So I think it would require maybe a little bit more of a discussion on what else are we going to do with this to try to get you a good response.
Absolutely. And what do you think about the safety profile compared to regorafenib? Interestingly, the control arm used the 160 milligram dose of regorafenib, where most of us are maybe implementing the redose type of schedule. And how do you think it compares?
Yeah, so I think, I will tell you, I was a little surprised that the safety profile was a little bit more toxic, because my own experience with regorafenib is that it's pretty tough. It's pretty tough on patients. The hand foot is not that easy to tolerate. The fatigue is, especially in these patients who've gone through FOLFOX, have gone through FOLFIRI, it's not the easiest to tolerate. So my thoughts on the safety profile are, they are what they are, right? I'm not going to take that away. My hope, though, is it does seem like my hope is that they're more manageable. They're over a kind of a longer course period of time, from what I understand in the trial, as opposed to Rego. You get those side effects pretty quickly. And so, we'll see. I haven't used this particular TKI in the clinic before. And so beyond my surprise, I don't really have any other thoughts other than, we'll see. But I'm hopeful that if it's more active, people will feel better from their tumor's perspective and hopefully be able to tolerate it. But it's something obviously we have to take seriously.
Yep. We were all a little surprised with the rates of toxicity as well. But I think, as you pointed, this is something we'll have to learn together in our clinical experience with this new compound. I think, bottom line is this is a welcomed addition if it gets an approval as a new option. And whether ongoing debates go with sequencing or whether to use it in non-liver and liver met, I think most patients that will be fit enough who ultimately get 4, 5, 6 lines, this is just another important line of therapy, in the treatment paradigm.
Absolutely.
So that was a great discussion on metastatic colorectal cancer with some recent coverage of the GI ASCO presentations. I'd like to move on to some breakthroughs and potential practice-changing studies in the adjuvant setting of colon cancer management, starting with the ALASCCA study. Dr. Patel, could you take us through the study design and key findings?
Yeah, so it was the ALASCCA study was a double-blind, randomized, placebo-controlled trial integrated into the Swedish Colorectal Cancer Registry. And basically, they looked at people resected stage 1 to 3 rectal cancer, stage 2 to 3 colon cancer, with somatic alterations in the PI3K pathway. And specifically, they randomized them to 1-to-1 within 12 weeks of after they had their surgery. They either put them on aspirin, 160 milligrams daily, so 2 baby aspirin, or placebo daily for 3 years. And all these patients also got adjuvant chemotherapy as indicated, right? Because some of them were stage 1, and so they didn't get it. And so that was essentially the trial. It was an adjuvant study looking at aspirin versus placebo.
Excellent. And what did the adjuvant aspirin compare to placebo in terms of some of the primary endpoints?
Yeah, so the combined estimate between, basically there's different kinds of alterations, there's group A alterations and group B alterations, but the combined estimate 3-year cumulative incidence of colorectal cancer recurrence was 7.7% for aspirin, and it was 15.4% for the placebo. Basically, about a half, I would say, half of a reduction in cancer recurrence in patients who had this mutation who were on the aspirin, which is, pretty pronounced, I would say.
Absolutely. And we also saw some DFS benefits of nearly 7 to 8% with aspirin and placebo as well. And so I wanted to get your thoughts immediately about the magnitude of these of the DFS benefit, because Mosaic, when it came out, was a DFS benefit of about 7% range. And you're achieving almost a similar DFS magnitude of benefit with a very, very safe, we routinely use it kind of method here. What are your thoughts on this?
Yeah, so I think that I love trials like this and trials like the challenge trial, which we'll probably talk about soon, where these are cheap drugs, right? Like we're not making anyone a ton of money, but we are helping people. And this is like a very real benefit, equivalent to what we are asking patients to do at times by adding certain chemotherapies and not just in colon cancer, equivalent to adjuvant benefits with osimertinib and, a lot of these other drugs in other tumor types as well. And so I think biomarker selected adjuvant intensification is really cool. The reality of, we just talked about it, the reality of our situation when we do have metastatic colorectal cancer is that we don't have that many drugs in our toolkit. And so preventing recurrence, regardless of whether we have a lot of tools in our toolkit, but especially because we don't have a lot of tools in our toolkit, is so critical. And so getting that big of a benefit from aspirin, I just think is awesome. And I'm very excited to see it. And I think implementing it is very important.
So on that point, how are you guys planning to implement this? Testing for PIK3 is not very standard across institutions. Tell us about your guys' plans or experience.
Yeah, so I send all my patients for NGS who have localized colorectal cancer cases because this is valuable, right? Like this is a huge benefit. And yes, of course, it's only like a small subset of patients that have these mutations. But I actually got to say, I saw a tweet this morning that talked about, there's a Nature Medicine paper about how whole genome sequencing directly led to clinical consequences in over 40% of patients in this cohort. Now, I am very pro NGS when it's possible for not just reasons that like this with the ALASCCA trial, but also because you don't know what other, we're always developing new biomarkers and, we didn't have MTAP drugs previously. And now, we think about sending them for early phase drug development trials all the time. And so I don't know. I'm a big believer. If there's a reason, you give me a reason to test for NGS, I'm testing. And this is my reason. Now, right before I wasn't doing that because, there wasn't really a clear reason or indication, but I think that this is enough of an indication to send them.
I agree. And it's such a favorable safety benefit profile, cost-effective drug. And I think actually implementing the NGS testing in localized disease, which we are as well, implementing across all localized colon cancer cases, will also open doors for earlier identification of treatments in the first-line metastatic setting, as we've highlighted in the BREAKWATER study. Now you're going to catch up your DPD testing. It just makes sense, I think, to catch all of these now with such a practice-changing study as well. So that's great to hear. And so moving on to another cost-effective, potentially practice-changing study. You mentioned this, the challenge study. Could you walk us through the challenge study?
Gosh, I think such a cool study. I mean, I love this study. I talk about it all the time. Phase 3 randomized control trial done in Canada and Australia in patients who are resected stage 3 or high-risk stage 2 colon cancer. And the idea was all these patients, they've completed their adjuvant chemotherapy within the past 2 to 6 months. And they were randomized. They were randomized to group number 1, which was a structured exercise program, which included support from a certified physical activity consultant for 3 years. And the goal of the exercise program was to promote aerobic exercise. And the goal was actually to get to 10 METs per week. And what the equivalent of that is about 150 minutes of walking kind of briskly per week. That's kind of the equivalent. But in the study, that what they actually did was tailor the activity to the person. So some people did rock climbing, some people did swimming. It was supposed to be sustainable, right, for the patient. And that's why the activity consultant was so important to that part of the arm. And then the control arm was people got general health education materials. They were encouraged, right, by their doctor to, we do that with all our patients, even before the challenge study came out, good diet, exercise, keep moving, all of those things. And so that was in the control arm.
What were the key findings of this study?
Yeah, so basically the key findings was, we were just talking about DFS earlier. I would say a pretty remarkable DFS benefit of 6.4%, 5-year DFS for the experimental arm, so the people who had the structured exercise program, was 80%, 80.3 compared to 73.9 in the control group. For recurrence, new primary cancers, or death.
Startling findings. And then in terms of secondary endpoints, did you want to point out anything with regard to overall survival or any other findings as well?
Yeah, so the 8-year overall survival which is like, also just side note, like what nice long like follow-up, which is like so helpful. And the authors probably knew that they needed that to have a meaningful study in exercise. But the 8-year overall survival was 90.3% in the exercise group and 83.2% in the health education kind of control group. And then I think importantly, they also had decreased liver recurrences and then, of course, decreased rates of new primary cancers like breast, prostate, colorectal, and then in those kind of in the experimental group as well.
I thought that was really fascinating to see how you could prevent systemic relapses with exercise. And the fact that you're reducing new primary cancers, I think really attests to the applicability of exercise across many different tumor types. So the immediate question then is, how are you incorporating the results of the challenge trial to your patients?
I mean, gosh, that's the best question in the whole world. And I absolutely wish I could prescribe a personal trainer or, something to our patients. And I just don't think we've developed the infrastructure to do that. And I think this is something that we're always having conversations about behind the scenes, at least at my institution. I'd be curious to know how you guys do it as well. But the way I do it, because I know that we have the limitations of the healthcare system that we work in, right? But I don't care because I want my patients to benefit. And so I spend a lot of time in my visit, right when I meet them, as much time as I'm talking about chemo, I'm spending the exact same amount of time talking about exercise and talking about what they're doing in their day, and I give them numbers because I think that it is extremely motivating. Every time I talk about the numbers of this trial and the DFS benefit and the percent recurrence and the OS benefit, you can see in their eyes that their faces almost light up oh, I didn't realize it would help that much. And if I am trying to convince you to go do this on your own time without a personal trainer, which is something I barely can do, right? I need you to understand that I'm not just saying that for the sake of saying that. I'm saying that because there's really good data behind it and I care about you. And so right now, that is my best avenue. I really hope we as an entire healthcare system, internationally, globally, figure out how to deliver this in a more meaningful way. But right now, I'm I can't wait for that. So that's basically how I do it.
No, I think you've really echoed the sentiments of all of us out here. It's very hard to have a structured exercise program. We do have, our PM&R colleagues, our cancer rehab colleagues, they, I've discussed with them, they really can't, have the bandwidth for such a magnitude of a program, but things to consider looking into local gym programs, may be a way to kind of network and broaden out the outreach for this. But I think I agree with you. Now we finally have some goal numbers, 150 minutes per week that we can really solidify in our discussion with patients. And I think that was another, important takeaway from the challenge study as well.
Absolutely. And I would also say, I talk about this with all my patients. It's actually not just our stage 3, high risk stage 2, because every single patient is what else can I do? And I'm look, okay, fine. This challenge study was not, and I tell them it's not in your, it wasn't studying your specific disease group. And of course, my patients who do have stage 4 colorectal cancer, I say that you might be limited by your ability, you're on Q2 week, Q3 week chemo. It might be hard. But that being said, there is value in movement based on kind of what this trial shows. And I believe in the biology of it. And so it's another way for me to encourage my patients to get up and about. And I think the numbers help. I really think they do.
Absolutely. And to attest to that, I have to shout out to my fellow Dr. Luisa Liu and my science partner, Dr. Jane Figueiredo. They recently presented an exercise study at GI ASCO on metastatic colorectal cancer from the Colorectal study. And again, you saw some benefits there too as well with exercise as well. So I think you're right. It should be applicable across all stages.
That study was awesome because fatigue is such a big problem that we have the most vague interventions for. And a lot of the interventions that we do have are not covered by insurance, right? We have things like acupuncture and massage and a lot of these things that some of my patients can't afford, right? And so being able to say, if you can get up and get moving, that's something that's free. And while I totally wish we could just get everything covered for our patients, it's another alternative. So I think that a shout out to your colleagues for sure for that.
Thank you. So moving on to another study that this one made into NCCN guidelines and it's more of a therapeutic study. So we're going to move back to therapeutics here for a little bit. The ATOMIC study was presented as a plenary session at main ASCO previously. Could you talk us through the ATOMIC study design and key findings?
Yeah, so the ATOMIC study was a phase 3 multi-center randomized trial in resected stage 3 mismatch repair deficient colon cancer. And basically, they were randomized to either FOLFOX plus atezo versus atezolizumab. FOLFOX plus atezo compared to FOLFOX alone. My apologies. But there was a third arm, I just will mention it, that was dropped, which was the atezolizumab alone arm that due to, I think, ethical concerns and low accrual, they had omitted it from the trial as the trial was going on. And essentially what they found, which I would say as like a community and understanding biology would expect, was that there was an improved DFS when, with the addition of immunotherapy to the normal adjuvant chemotherapy that we give. And so the DFS benefit was 3-year DFS was 86.4%. And in the FOLFOX kind of chemo alone arm, it was 76.6%.
Thank you for highlighting that. It was a positive study, and because of these results, the NCCN did update that this is a category preferred across oxaliplatin-based regimens for mismatch repair deficient stage 3 colon cancer or high risk stage 3 as well. And they consider it for mismatch repair deficient stage 2C, so kind of a high risk stage 2 adjuvant setting for MSI high, with a lower category recommendation consider. How are you implementing the atomic results in this population?
So yeah, I will say that I'm, of course, absolutely implementing it, right? And I would say that we at Stanford, we were trying to use it even before the atomic came out. And I think a lot of doctors across the country were doing similar based on the results in metastatic colorectal cancer with mismatch repair deficiency. And so I would say we're absolutely using it in all low risk, high risk, stage 3, all of the patients. I do think that there is a discussion to be had about the neoadjuvant using immunotherapy versus going with the adjuvant. And so that's something maybe we can talk about in a second, but I am using it for all my patients. And in the T4B patient population, the stage 2C, I think it's reasonable to use it in those patients. I do think it would probably depend on a little bit more of what I see on path as well. If they have like some high risk features, I would probably use it. I just think because biologically these tumors are highly immunotherapy responsive, if they do recur, I think if their ctDNA isn't positive, I might think about it. I think that's like more of a multidisciplinary discussion and things like that. But I wouldn't say I give it to all patients who are 2C.
Gotcha. And I think you highlight on a bunch of important points. For the longest time, we all knew we should be doing it, but NCCN, consensus guidelines still recommended oxaliplatin-based chemo alone for stage 3 MSI high adjuvant treatment of colorectal cancer. So I think this study was important just to know that, yes, it works. It is now in NCCN guidelines and is a consensus recommended option. However, you hinted at this too. Is this the ideal setting that we should be giving these patients immunotherapy? There's a lot of data in the neoadjuvant setting. What are your thoughts on that?
Yeah, it is hard to ignore, right? The neoadjuvant data. It's less immunotherapy exposure. For the listeners, niche 2 is probably the best example of it. But there are multiple kind of smaller studies that show pretty high in the upwards of 95% pathologic complete response with a few doses of immunotherapy prior to going to surgery. And so I think the field is increasingly moving towards getting your you get the colonoscopy, you get the tissue, you check for mismatch repair deficiency. And if there is mismatch repair deficiency, leaning towards doing neoadjuvant immunotherapy, seeing if you can get a pathologic complete response, and seeing if you can do non-operative management altogether. Now, I will say, I do think we need a little more data before we stop cutting parts of people's colons out. That's my personal feeling. I am not fully sold on using just ctDNA to monitor these people because not all tumors shed, and we're talking about like really earlier stage colon cancers. And so I would like, before I am saying we don't do, operative management, I personally would like to see some more data, but I know a lot of my colleagues are doing that. And so, but the reality is that a lot of these patients do come to us already having their tumor excised. And so atomic is so important because we were in a data-free zone. A lot of us were using it. A lot of us weren't, and I think having this data was so important. But I think in general, the practice patterns are likely going to be moving a little bit more towards neoadjuvant in this patient population.
Agree. A very highly evolving subset within colon cancer management. And last but not least, Dr. Patel, we've been talking metastatic, adjuvant, what about primary prevention of colon cancer? And there was a study presented at GI ASCO. It was a rapid abstract of GLP-1 receptor agonists. Could you take us through the study design and the key findings for this study?
Yeah. So I feel like GLP-1s are all the rage. Everyone's talking about them. All the companies are coming out with their compounded versions. I think this was a very important study for our patients, and not just our patients, but people who don't want to be our patients, right? Because primary prevention. And so this was a real world head-to-head comparison of people taking GLP-1 receptor agonists versus aspirin, which we were just talking about earlier, using a database of 150 million patients across about more than 100 health organizations. And essentially, they had two cohorts, the GLP-1 user cohort, aspirin cohort, and they looked at the primary endpoint, which was, did they get colorectal cancer? And the primary endpoint, the colorectal cancer incidence was 0.13 in the GLP-1 group compared to 0.176 in the aspirin group. And so about a 26% relatively lower risk of colorectal cancer. And they did see the benefit consistent across most of the subgroups they looked at. So age, BMI, diabetes, tobacco use. And so, and then in terms of safety profile, they found a favorable, consistent safety profile, which we know is abdominal pain, some diarrhea, more frequent with the GLP-1s, and then slight increase in GI bleeding with the aspirin.
So what do you think are the takeaway messages for this study?
Yeah, so I think the takeaway message is that it's extremely interesting. I think the takeaway is also that something that we already know that we don't really like to know, which is that there are obesity-related cancers. They exist. They existed before GLP-1s existed as well, right? And we know that obesity is one of the risk factors for developing these obesity-related cancers. And so, which colorectal cancer is one of them. And so my takeaway is not so much everybody should be on a GLP-1, right? The takeaway is that, wow, we have a drug now that can not only help people with their cardiovascular risk, and I think there's sleep apnea benefits. Well, I was seeing, I think in one study, I think that they're looking at it for addiction, right? It's doing a lot of good for a lot of people. And I think the good that it might do for cancer is not necessarily a primary cancer prevention so much as it's getting people generally healthier, reducing inflammation in their body, which then in turn is maybe reducing their risk of colorectal cancer. And so I think it's more of I don't know that this is necessarily ready for prime time, so to speak, of let's roll out GLP-1s as a cancer prevention tactic for everybody, so much as these medicines are extremely valuable and helpful to control obesity, which has multiple health benefits, which includes reducing cancer risk.
Thank you for summarizing that very well. It's nice to have that reassurance that, hey, your medicines are helping you with your other comorbidities, but guess what? It might be helping you preventing cancers too. So that's always makes our discussions with the patients so much easier.
Absolutely. Absolutely.
Dr. Patel, it was amazing having you on the podcast. We did a whirlwind tour of metastatic adjuvant and primary prevention. I'm sure this will be beneficial to all the podcast viewers and beyond. So on behalf of BackTable Tumor Board, I want to really thank you for coming on.
Thank you so much for having me. This was so fun.
All right. Awesome.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.